Good morning, everyone. Thank you for joining PHCA for today's webinar, PDPM Impact, Early Lessons, Analysis, and Strategies. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for one continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number. I'll be sending a link to a quick survey. Your feedback is important to us and our speaker, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit your questions using your questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Today's webinar is being presented by Bill Goulding, who is the lead post-acute healthcare consultant, Post-Acute Care Solutions with Aegis Therapies. While most of the skilled nursing facility industry generally knew what to expect from PDPM, there was plenty of room for surprises, and some have been significant. Today's session will review comprehensive operational and clinical data. The data will include nursing and NTA results, in addition to the 3 therapy disciplines. Clinical and operational trends will be discussed, as well as early strategies to mitigate negative trends where possible. There will be specific recommendations regarding aspects of SNF services and practices that must be monitored going forward in order to be successful in this new payment. I'll now turn the webinar over to Bill.
Well, thanks, Wendy. As Wendy said, my name is Bill Goulding. I'm a speech pathologist by background, but since 1984, I've spent my career working for contract therapy organizations and consulting organizations, and all in post-acute care. And as she mentioned, the organization I work for at this point is called PACS, or Post-Acute Care Solutions. Our affiliation with Aegis Therapies is that we're both owned by the same owner, but it does give us some access to the information that Aegis has in their 700-some facilities that they service across the country. Because I'm a certified resident assessment coordinator through ANAC, what I spend a lot of my time doing with current customers right now in the rollout of PDPM is remotely going into their electronic health records and helping them with their new admissions and the MDS coding and maximizing their HIPS reimbursement. So that's my background. So as I go through this, I'm going to ask for a little bit of patience because there are times, I'm sure, when slides will come up on the screen and you may say, oh, this is going to be too basic, or I know all of this stuff, it's not coming in at the right level. I'm trying to walk a tightrope here because I assume we have a decent range of comfort levels with PDPM among the callers. So I wanted to make sure we don't leave anybody behind. I won't spend an awful lot of time on the basics of PDPM, but when I do present the early lessons and some of the utilization trends that we're seeing so far, I want you to understand what they need. And so there has to be, by definition, a little bit of review. And so just a quick reminder before we get into some information on what's happening on the PT and OT side, and then we'll look at the other components of PDPM. Just a quick reminder that PT and OT are driven by 2 basic questions. The first is, what clinical category is the resident in? And as most of you know, they'll be sorted into one of 4 clinical categories: major joint replacement or spinal surgery, other orthopedic, non-ortho surgery, and acute neuro, and medical management. So those are shown on the left side of the screen. And the second question is, what functional level are they at? And I'll have plenty to say about how functional level is determined under PDPM and how that process, specifically section GG scoring, may be defining part of our future from a reimbursement and maybe even a placement standpoint. So I'm going to have more to say about section GG in just a little bit. But essentially, everything else on this table is driven by those first two questions. What clinical category are they in, and what's their functional level? And that's how the case mix index, or the multiplier for PT and OT, is determined. So let's look at that first one, clinical category, and see what we've been seeing so far in the first, call it 5 months or so of PDPM. Some of the data that I'll be showing you comes from another healthcare consultant, Zimit. Some of it comes from PACS, my organization, and our customers, and also Aegis and the customers that they're servicing. So that represents about 700 plus facilities. And so here's what we're seeing across the first 4 months in PDPM. So that's through the end of January. As far as that first question for PT and OT, what clinical category does the resident fall into? And so what you're seeing here is up at the very top of the pie at 6%, that orange slice is major joint replacement or spinal surgery. Next to that, to the right, the bluish slice, 22%, is other orthopedic. The really big slice, 55% that you see, that's kind of a purple color, that's medical management. If you remember, that's actually the conglomeration of 5 different clinical categories that seem to be fairly different from each other, but the actuarial company, Acumen, that did the slicing and dicing behind the scenes for CMS, found that there were enough consistencies across those clinical categories to group them together when they're trying to determine what sort of resources such a resident might utilize. So that's the biggest slice. And then that 17% slice is for the non-ortho surgery and acute neuro. But what I thought I'd do is just remind you, among these 4 categories, how they impact case mix. And if you're not familiar with seeing case mix numbers, I've just put the number 1.53 in that 6% slice of the pie. What that means is, for major joint replacement or spinal surgery, which is what that slice of the pie represents, the base rate for PT or OT, which is going to be different based upon geographically where you are, wage index, all of that sort of thing, the base rate for PT and OT is going to be multiplied by 1.53. So you can think of the case mix index, if you're not familiar with looking at them on a regular basis, as a multiplier, and therefore the higher the number, the higher it's going to multiply PT and OTs or whoever's contribution towards your per diem. So 1.53 is the multiplier for that major joint replacement or spinal surgery. That group of 22%, the multiplier for other orthopedic, which is that blue slice, the multiplier or case mix index is 1.45. That slice that represents 17% is non-ortho surgery and acute neuro, and the multiplier for that, or the case mix index, is 1.36. That's the average across all different functional levels for that clinical category of residents. And then finally, the big slice of the pie, where we're saying in these 700 some facilities, more than half of the residents classified is that medical management, and the multiplier there is only 1.32. So again, you're going to get about a third again on top of the base rate for PT and OT for residents in that category. So you can see the difference, the range across those 4 clinical categories and how they're sorting out right now. Keep in mind that of the 17,000 or so ICD codes that are out there, only a little over half of them will sort into one of these 4 categories. And somewhere in the maybe 45%, I don't have the number right in front of me, will sort into a return to provider. They won't categorize in any one of these categories. And so hopefully you've got something that's helping with that. So let's talk about some of these lessons learned from such data. One is, again, we need to have scrubber processes, both IT in your electronic health record and human processes, to kind of double check and make sure that we're making the right decisions here. These categories, for those of you who don't get into the weeds or the nuts and bolts on a daily basis, these are being driven by one ICD code that we choose to put in a specific section in the MDS called I-20B. So it's in section I. I-20B. And so we need, here's the number I was grasping for before, 48% of those 17,000 ICDs will result in a return to provider. And so there are crosswalks on CMS's PDPM page, Excel spreadsheets that you can use for this and for other ICD crosswalks, for instance, for NTA and for some of the speech comorbidities that we'll talk about later. But it's cumbersome. And if you're not familiar with using it, what I'm hoping is that you've got a scrubber in your EHR system that's helping you to understand where that code that you would put in I-20B would sort the resident. And just a reminder, I'm still seeing customers that are falling into the habit, it's understandable, what we've done for decades, and that is to focus on the condition that was the reason for the hospital stay. For PDPM, what we're looking for in that I-20B slot is the reason for the SNF care. And so that's what we want to focus on. It may be the same as the reason for the hospital stay, but it may not be. And so that makes it a really difficult decision. So hopefully your scrubber is telling you, don't even consider these codes or these codes, because there'll be an RTP, a return to provider, meaning no reimbursement. But these are the codes for you to consider, and that's where you've got a clinical decision to make about what's the primary reason for the SNF care. And so that you get credit for that care, which is what this is all about, giving yourself credit for the unique residents that you're dealing with. And just as kind of a reminder, that other ortho category, that would be that bluish slice of the pie, those are things like, rheumatic issues, a wide range of issues, some contractures, some diagnoses for low back pain, bursitis, and so there's some fairly common codes that if you determine that's one of the primary reasons or the primary reason for the SNF care, that might be a category that you would qualify for. And again, you'd be giving yourself credit for dealing with a resident in that category. By the same token, acute neuro, that is that non-ortho surgery and acute neuro slice of the pie. It's sort of brownish, 17% there. And things like poliomyelitis, encephalitis, ataxia, Parkinson's, some of the speech and language I codes. And what I mean by I codes, for those of you who aren't familiar with ICD coding, I codes are generally neurogenically driven codes. And so it can be an aphasia or dysphagia or some of those speech comorbidities that we'll talk about that start with an I, meaning they have a neurogenic cause. And so they would not only help you with your SLP classification for PDPM, but they may, if you decide they're the primary reason for the SNF stay, put the resident in a category with a higher case mix index, meaning you're giving yourself credit for a more complex patient if you're using those. And so, again, it just needs to be not just an EHR process, but a human process, making clinical decisions. Back to where we started with PT and OT, what we just discussed was the answer to the first question, clinical category. Let's talk about that second question, the functional score. And this brings us to our discussion, section GG. But let's talk about it. Just if you're not familiar with section GG functional ratings, it's for PT and OT, a resident can score anywhere in the 0 to 24 range. 0 means a resident who is completely dependent for all 6 areas that were rated. 24 means a resident that is either completely independent or really just needs setup. So in other words, you might call it modified independence. So the higher the number, the more independent the resident. So with that in mind, take a look at this information. That huge slice of the pie that jumps out at you, that green slice for 60%, those are residents in that 10 to 23 range. So again, remember, the closer you get to 24, the closer you're getting to independence. So that's a big range from 10 to 23, but that's where most of the residents are falling. Remember, this is at the 5-day. This is at admission. So we're saying these residents who are coming in post-acute care are really, I would say, more independent than I would have expected. And that's one of the things that we want to talk about. I have a feeling with the customers that I'm working with that we are overrepresenting the independence levels of a lot of our residents, and many times that's because we're being over-dependent upon Therapies ratings. And remember, this is coming from a therapist, but the therapist's view is not necessarily the view that CMS is looking for. It's part of the contribution, but it should not be the sole view. So let's talk a little bit more about that. Kind of the lessons learned or the things we need to consider. First of all, what CMS is looking for in the RAI manual is input across the first 3 days. So we're looking for multiple snapshots of this resident's function in the areas that you're rating. And so, and ideally, snapshots from different photographers, if you will. So different observers, at least 2 different factions, if not more, contributing to this information. ANAC has a nice little resource to track this process, the collaboration across time and across different reporters. And so that's something, if you don't have availability to find that, we're going to make sure that you've got my contact information. Again, it's just bill.goulding@paxconsulting.com, but you'll see that again. And send me an email. I'm happy to send you resources that I have found to be helpful, and that's one that can help with this part of the process. So again, you want to get it across 3 days, multiple sources. What we're looking for is a depiction of their usual function, not their best function, not their worst function, but their usual function. And so just that term usual denotes that what we need is looking at them different times of the day, different days. Those are the things to keep in mind. The other thing I'm finding with a lot of my customers is they're doing the GG scoring with fairly narrow definitions in their head as to what it is they're rating. And so, one of the things we're doing is giving tip sheets to remind people of the broad definition of some of these categories. For instance, just simple examples: shower and bathe. When you're rating in that area, it includes washing, rinsing, and drying. So we're looking at usual function for all 3 of those tasks. And for one of them, it might be very different. And if that results in a burden of care, we want to capture that, give you credit for it by making sure that we're giving realistic GG scores. Eating is solids and liquids. So it's not just one or the other. It's really both. And so if they have an issue with one and not the other, their usual function is going to be pulled down by that fact. Just some simple things that those of you who don't do GG scoring on a regular basis, it's on a 1 to 6 scale in each area that we're rating. And 6 is most independent for whatever area that is. Let's say it's eating. And 1 is most dependent. And so just a reminder that anytime you have to do any setup for any one of these parts of the tasks, they're automatically a 5 at best. Anytime any supervision is necessary. So again, this might not even be physical or cognitive cueing or assistance. That means they're going to be a 4 at best. So these are just reminders that my sense is that many of my customers are overrating their residents and therefore not giving themselves credit. And really the first decision that you make when you're doing GG scoring is, am I doing at least half the effort? And if that's the case, as the caregiver or the helper, the 2 is the best they can do in that 1 to 6 scale. And so just I found the need for lots of reminders and retraining on section GG. So those are the 2 questions for PT and OT. What clinical category are they in and what functional level are they at? And this is the distribution that we're seeing across those 700 some facilities across the first 4 months. So what I've done is, rather than give you the TA, TB, TC, TD, all those little acronyms for the PT and OT categories, what I've done is I've split it into those 4 functional groups. And so you can see, for instance, the other ortho on the left. So that's that slice of the pie that we saw before, now split into the 4 functional levels. So within each of those 4 groups, the more you slide to the right within that group, the more independent that resident is being rated. And so, for instance, for the other ortho, that 13% you see spiking up, those are other ortho residents that were rated in that 10 to 23 range on the functional scale. So, pretty independent, especially considering there's a 5-day admission assessment, and we're looking at the very first 3 days after they get in the facility. And then you can see the same thing for non-ortho neuro. Again, it's that third bar that pops up. That's that 10 to 23 function group. Medical management, no surprise, 40%, 39% are in that group. And then you see the smallest group, the major joint and spinal group. So that's kind of how the distribution has fallen out so far. So let's move on. There are 5 major components: PT, OT, speech, non-therapy, ancillary, and nursing. We talked about the first 2, PT and OT. Let's talk about speech. As a speech pathologist, I can make fun of speech pathologists. PTs and OTs made it easy, just 2 simple questions. Speech tried to cut it down to 2 questions, but they're really 2 multi-part questions. So the first question is, is their condition an acute neuro condition, and/or do they have one of 12 speech-related comorbidities, and/or do they have at least a mild level of cognitive impairment? So that's the first multi-part question, and our answer to that is going to be yes, all of the above, 2 of the above, 1 of the above, or none of the above. So when I present the data to you just in a little bit here, I'm going to be presenting it to you in how we answered this 2-part question. And the first part of that answer is going to be all 3, any 2, any 1, or none. The second multi-part question that's asked by the software, the PDPM grouper, looking on the MDS is, do we see an indication that they need a mechanically altered diet, and/or do they have a swallowing disorder? And so the answer to that is going to be both, either, or neither. So when I present the data to you, it's going to be, they answered the first question, all 3, any 2, any 1, or none. And they answered the second question, both, either, or neither. Hopefully that'll make more sense once you see it breaking out. But after you answer those 2 questions, you can see the case mix index. I do want you to take a peek at those far right scales, far right columns there. Look how quickly from the bottom of the table to the top, the case mix index for speech escalates. If you answered the first question, none of the above, and the second question, neither, so where I'm looking at the bottom row of that table, you would be an SA. And so look at the case mix index for that, 0.68. That means you're taking your speech base rate of $22, and you're only getting 2/3 of that, so you're getting a little over $15. These are generic rates. Yours might be different based upon your locality, et cetera, wage index, et cetera. But then you can see how quickly it escalates. Once you start to answer some of those questions, yeah, 1 of the above, or either 1 of the second question, you can see how quickly that case mix index climbs as you go up that second to right column. That's basically CMS's indication that what they found from Acumen, the actuarial company who did this slicing and dicing and helped to design the system, is that once some of these things come into play, like a mild cognitive impairment or a swallowing disorder, things get messy really quickly. They get complicated, and the cost of delivering services goes up. And so that's why that case mix index escalates so quickly. And that's why I'm focusing a lot of my customers on making sure that they're giving themselves credit in this SLP area, and not just defaulting, if you will, to an SA category where they're answering no to 5 straight characteristic questions about their residents, and not giving themselves credit, where CMS is saying, boy, if one of these things is happening, you really need to be reimbursed at a very different rate. One of those 5 parts of the question was, do they have any one of 12 speech-related comorbidities? These are found on the MDS primarily in section I. A couple of them, the vent trach, are found in section O. Some of them are in section I, the checkbox part of section I. Those of you who are familiar with the MDS. Several, though, come from section I-8000, which is one of the scariest parts of the MDS under PDPM. It's just blank sections where you have to choose one of those 17,000 ICD codes and choose the right one. So this is, again, where your EHR scrubber is going to come into play and help you to focus on those tools. There are, again, ANAC has some nice cue cards, if you will, on this. There are other consulting firms, BKD, I just did a presentation with yesterday, and they have some very nice resources. So again, if somebody feels like they need special focus on one of these components and they're wondering about some resources out there, if you want to send me an email, I'd be happy to send you what I have to help out. But as you look at these, just keep in mind, most of these are going to be ICD codes that start with an I, as I mentioned earlier, which means they're neurogenically driven. There's some neuro cause behind the apraxia or the aphasia or the dysphagia or whatever the case may be. So here's the distribution. It's a little hard, and this comes from Zimit, another healthcare consultant, and this is it's harder to display. You look at this pie, and it's not just 4 pieces of a pie; it's 12 pieces of a pie. So what I've done here is I've kind of labeled each of these categories with the answers to those 2 multi-part questions. So in other words, the biggest piece of the pie is that 33%. That's SA. That is the one, just as a reminder, where the case mix index is 0.68, meaning you're not going to get your full base rate for speech. You're going to get about 2/3 of it. You're going to get 0.68, 68% of that. And they're an SA if we answered none to the first question. That means, nope, they do not have a neurodiagnosis. No, they do not have even a mild level of cognitive impairment. And no, they don't have any one of those 12 comorbidities that we just looked at. Then we went on and answered neither to the second question, meaning, nope, they don't have a swelling problem, as demonstrated in section K of the NDS. And no, they don't have an altered diet. And so we answered no to 5 questions. And so basically CMS is saying, well, you don't need an awful lot of funds to care for the characteristics that normally go with the speech and swallowing patient. But remember how quickly it escalates if we start sliding up to SB, SC, SD, and where we start to answer yes to some of those questions. So, but you can see the largest categories here is 33% is for SA, 23%, that purple slice, is for SD. SD is where we answered one of the above to that first 3-part question, and neither to the second 2-part question. So, fairly minimal. So we either said, yeah, they've got a mild mild cognitive issue, or yeah, they've got a neurodiagnosis, or yeah, they've got one of those 12 comorbidities. But that's it. We answered no to everything else. So over 55%, 56% of residents are falling into those 2 baskets. So this has been an early focus area for me with a lot of my customers to make sure that they are capturing these characteristics. And an awful lot of it, let's talk about the things to consider. First of all, we need to look at cognitive function over time across shifts. I think the way that currently the PDPM system is structured, we've got a bit of a bottleneck. And that is, cognition is determined by the BIMS unless you answer a question, kind of a gateway question, that says, is this resident rarely or never able to make themselves understood? That's a very high bar. And if you answer that question, yes, then you can go to a staff assessment, which I have found to be much more sensitive to mild levels of cognitive impairment. Whereas the BIMS, I think, partly because it's the BIMS, and partly because I think the way we're administering the BIMS sometimes is too perfunctory, or we're not looking across different times of the day, or early enough in the resident's stay with us, and we're getting vast majorities of residents just going through with flying colors on the BIMS, therefore representing them as no cognitive impairment, not even a mild level. And most veterans in SNF care will say intuitively a huge proportion of those in most SNFs have at least a mild level of cognitive impairment. So that's one thing, to look over time and across shifts, to look at our process for scoring the BIMS, to make sure we're not rubber stamping this, and to make sure that we're trying to do this at different times when the resident may be challenged. That may seem like cheating, but again, what we're trying to do is give the best picture of what that resident's function is in their time with us. And so we're not just going to give them the best picture, we're going to give them a picture of what we have to deal with. For speech, those 12 comorbidities, we just have to keep in mind that what we're looking for is ICD codes that start with I. Speech pathologists are used to using, for instance, for dysphagia, ICD codes that start with R that get very specific about the phase of the swallowing problem. Those are still legitimate. They're not the ones that are going to give you credit for a swallowing comorbidity. And so what we need is an I-8000 to have some of those I codes popping up, and they can be backed up with those R codes that the speech language pathologist feels is important and is indeed important. But what I've been really asking my customers to think about is getting the SLP in early to do an evaluation, because PDPM asks us questions about every resident on their cognition, on their swallowing related issues, and whether there are sequelae or symptoms that are due to neurogenic disorders. Even if we might think they're inactive, an old CVA or something along those lines, or Parkinson's that may not have had much to do with the reason that this resident was recently hospitalized. But we have to ask ourselves, are there sequelae or symptoms that are impacting the current stay? And so getting that SLP in early to give everybody the information they need on cognition and swallowing and other issues, I think is something that makes sense because of the way PDPM is structured. So let's move on to nursing. We have two categories left, nursing and NTA. Nursing, again, for those of you who are doing this all the time and did it under rugs, the nursing categories look fairly familiar. They really have just been collapsed and kind of cleaned up under PDPM, if you will. But we have some familiar categories here. Right at the top of the tree is extensive services, then special care high below it, special care low below that. And I'll continue to go down on subsequent slides, but I want to point out that extensive services is kind of an exclusive club, only certain ways to qualify for that category. But special care high and special care low, one of the things we need to keep in mind here is whether there's evidence of depression. And that's going to be based upon that, generally, the PHQ-9 scoring of mood. That also has a very high bar to clear in order to bypass the PHQ-9 and do the staff assessment. But depression can make a big difference. If you look at the case mix indices on the far right, you can see that a special care high, HDE1 with no depression, the multiplier of the case mix index is 1.99, whereas if they do have depression, CMS is saying give yourself credit for that. You're going to need extra resources, and so we're going to multiply your base rate for nursing by 2.39. So it makes a difference. So it's important to look at the way that we're scoring depression. The second box that I have on the screen is the GG scoring. And again, we're going to talk about the GG scoring for nursing because it's a little bit different. I'll make sure you understand how it's different and why GG scoring is really so important, even outside of PDPM. But as we go down, further down, just as background so that you'll understand the data that I'm about to show you, we have special care low. Below that is clinically complex. And again, you've got the same questions in these categories for depression, yes or no, and GG score. So those are the key things to keep in mind for those clinical categories. And then we continue down to the very bottom of the nursing groups. Clinically complex continues here. And then the behavioral and cognitive, and then the physically reduced function. And here's where some of those splits differ. For the bottom two nursing categories, they're looking at whether restorative nursing services are being supplied or not. And so these are residents that if you're finding residents dropping into these lower nursing categories, these are the ones you might want to slide your ARD back a day or two in order to capture restorative nursing services, at least 6 days, and to get those in there, because it can make a difference as you look at the right-hand side on your nursing case mix index, the multiplier. But you'll see they're also looking at the GG-based function score for these bottom two. So those are looked at for every nursing resident. Here's how the nursing categories have been distributed in actual usage across the 700 sub-facilities that we looked at for 4 months. Again, not unusual, not all that different than under RUGs. The Special Extensive Services, fairly exclusive club on the left. As you're moving to the right, you're generally getting to the lower case mix index or lower reimbursement categories. But special care high still kind of leads the way. Special care low, then clinically complex, you can see, and then the bottom two categories that we talked about. The things to consider here, one is respiratory services. There are residents that I'm seeing with customers that are not receiving respiratory services. Now, and that can qualify you for special care high. So residents that come in with respiratory concerns and or that had respiratory services in one way or another in the hospital really should be considered getting someone in to do respiratory therapy services. What you need to qualify for special care high is 7 days worth of respiratory therapy services, at least 15 minutes. So, that's something to keep in mind. And again, that might be a resident where you're going to slide an ARD a day later or two if you were a little bit slow on the uptake and getting those services made available once you identified the need for it. As I mentioned as we went through, depression scoring, really important for special care high, special care low, and clinically complex categories, those three middle categories, if you will. And they make quite a difference in the case mix index. So I'm not just saying go for the highest dollars. I'm saying if that's an issue, depression, give yourself credit for it, capture it. Think about how you're doing that PHQ-9 scoring in the mood section. And if you're finding, as I said, if you're finding your residents drop into those lower categories, the behavior, cognition, or the reduced physical function, that's when you want to think about, are we doing restorative nursing to at least give ourselves credit for all the things that we're trying to do to maintain or improve this resident's independence with ADLs and those types of activities that are a focus of restorative nursing. And then I'm going to pound on this several times, and that is GG scoring. GG scoring is not just about therapy. It's obviously about therapy and nursing, every single one of those categories. And it's not just about PDPM. So we'll talk about this in a minute, that with GG scoring, I'm convinced that we are creating our future for how reimbursement will be divvied out and maybe even resident placement. And so we'll talk about that in a minute. For section GG, as I said, it's a little different. Before I show the nursing scores, I want to show you how different section GG scoring is for nursing versus therapy. Essentially, side by side, what you're seeing here is nursing doesn't look at the mobility or oral hygiene, which is at the bottom of that therapy table there. So they're looking at all the other areas. So you can see they're looking at 4 buckets of function. I'm looking at that right-hand column, whereas therapy is looking at 6 buckets of function. And I say buckets because sometimes they're looking at multiple mobility measures or multiple transfer or multiple walking measures, and they're averaging them together for one score for bed mobility, or one score for transfers, or one score for walking. So nursing ends up with 4 function scores that can be anywhere from 0 to 4. If you remember, when we looked at therapy, they had 6 areas they looked at that could be anywhere from 0 to 4, which is why when I showed you that data, it ranged from 0 to 24 total. So the nursing is going to range from 0 to 16, and here it is. And again, this comes from Zimit, the other healthcare consulting company. They're essentially showing those. Remember, the higher the number means they're more independent. That's about 6% of the residents at evaluation, at the 5-day. In fact, in the first 3 days of their stay, are in that 15 to 16 range, meaning they are essentially independent or just needing set up in all 4 of those buckets of function, if you will. And that nearly 3/4, 72.6%, are in that big 6 to 14 middle range, and about 20% are in that pretty dependent range, 0 to 5. Again, I wouldn't be surprised by some of these numbers later on in an IPA or in a discharge summary, but I have been surprised over the first few months by how independent we're portraying our residents in this first 4 months. And I think a lot of it has to do with how we're doing GG scoring, who we're getting input from, who we're not getting input from, where that input is coming from, whether it's really usual function across those first 3 days or not. So things to consider, same things that I talked about with functional scoring for therapy. And this is literally the same bullet points because we have to think about the same things. Across the first 3 days, use multiple sources, think about usual function, think about the full definition of each activity, and just a few scoring cues that, I think people have kind of let go by the wayside as we're focusing on so many different things and trying to get this done quickly. Non-therapy ancillary. This is the last one of the 5 components that I'll talk about. Non-therapy ancillary, or NTA, is the hallmark piece, I would say, of PDPM. This is the most, radical in some ways, but also hopeful components of PDPM, because it's Medicare's first attempt to quantify just how medically complex our residents are. We've been screaming at them for decades. You don't get it. You either don't get it or you don't care how medically complex our residents are. And so now they're, in essence, calling our bluff and saying, okay, we're going to put in place a system where we're going to identify 50 conditions and services, and we're going to give different weightings to those 50 conditions and services. And you're going to tell us to what extent your residents have these or need these. And we're going to begin to build a picture of the medical complexity level of SNF post-acute care residents. So I'm not going to go into the detail here, but just so you get a general feel, if you don't deal with this on a regular basis, what you see is the beginning of a list of 50 conditions or services, and you see HIV/AIDS at the top. They learned that on the SNF claim. All the rest of these come from the MDS. But if you an HIV/AIDS, it makes sense that that's a really complex resident. They're going to give you 8 points. Where this is going to end up is a scoreboard that tops out at 12 points. Gives you the highest case mix index for 12 points. So you can see how significant that is. Parenteral IV feeding, you can go down the list and see that fairly quickly we're moving towards about 70% of these 50 conditions and services just give you 1 point. So I won't go over each one, but as you kind of glance at these, you get a sense for really how prevalent a lot of these things are. Morbid obesity is not based upon BMI, it's based upon a diagnosis that can come from the physician. And so it might be a consideration that's broader than just looking at BMI. Malnutrition, same thing, not based upon a BMI score. That's part of the consideration for the physician. But it's one of those things that, again, we have to ask ourselves, are we giving ourselves credit? Part of the problem with NTA is that middle column, the source. It comes from so many different areas of the MDS, and so many of those are I-8000. That's that scary area that I mentioned, where it's just open fields where you've got to choose out of the 17,000 ICD codes, the magic ones that qualify for these. So again, there are crosswalks on the CMS PDPM site that will let you know specifically for endocarditis or the immune disorders, which is a huge category, which specific ICD codes would qualify in I-8000 and give you that one precious NTA point. Your software scrubber may be helping you with that. There are also some nice resources from several different sources that I use. And so again, I put out the offer that if you want to send an email and ask me for resources on NTA, if that's something that you really want to focus on, I'll send you what I have found to be helpful so far. So that's NTA. These are the end of the 50 conditions. And here's the scoreboard that it all contributes to. So just to keep in mind, the higher the NTA number on the left-hand side, that means the more medically complex we've painted the picture. And you'll see the case mix group, or CMG, NA, NB, and C. In this case, the lower letter means more complex. So I'm not sure why they kept flipping these around on us. But look at those CMIs, the second to right hand column, and look at, again, how quickly they escalate. you're taking the NTA base rate, which is already pretty hefty, in this case, on a national basis, close to $80, and then you're multiplying it. After this resident is identified as having more than 2 points, so 3 points and above, you're getting a third again as much as that $80 on top of it, 1.33. And then look at it escalate to almost double, 2.5 times, over 3 times that base rate. And keep in mind the NTA is then being tripled your first 3 days because the actuarial company that put this together said NTAs are front-loaded activities. These are sometimes equipment or supplies necessary on the front end, and/or staff training, or staff time to set things up. And so nursing facilities need to be reimbursed even more. So if you're not giving yourself credit for NTAs, you really are cheating yourself. And the way to convince yourself of that is to see how seriously CMS took it in those CMIs, and then consider the fact that they're tripling that during the first 3 days. Here's the distribution, and keep in mind here, I'm going to put the scores at the bottom. The NA on the left-hand side are those who are very medically complex. They got 12 or more points. The NF on the right-hand side, 0. Of all those 50 conditions and services, not one was identified on the MDS. So what you're looking at here in the first 2 columns on the right, NE and NF, is essentially half of the residents are only getting 0 to 2 points of those 50 conditions and services. So, that's the picture we're painting after all these decades of saying our residents are really medically complex. And so, what are the things we need to think about? First of all, 1 point really matters. Let me just show you a monetary example here. We have a resident sort of in that middling range, let's say 6 to 8 points. They're an NC. The case mix multiplier is 1.84. So here's how the math works. You take your base rate. I took the urban national base rate, $80.45. You multiply by that 1.84. In the first 3 days, you then triple that. So your per diem for the first 3 days of the stay for this fairly middling resident in the 6 to 8 point range for MTA, $444. That's just the contribution from MTA towards your per diem. That doesn't include what nursing is throwing in the bucket, what PT, OT, and speech are throwing in the bucket. Let's say we found one other thing, malnutrition or morbid obesity or something like that, one other point that pushes them up into the NB range. Here's how that math works. Now we're multiplying by 2.53 instead of 1.84. Because again, CMS is saying things get much more complicated the more you start piling complexity on top of complexity. So look what it does during the first 3 days. The per diem, just the NTA contribution, is over $600. And on the top of the slide, I just kind of calculated for a 20-day stay what a difference it would be to find one more point for your NTA. It means over $1,400 for that 20-day stay. And again, I'm not talking about upcoding here. I'm talking about making sure you paint the most accurate picture of just how complex your residents are. And if you're not, these are the sort of dollars that you're missing out on. You're still giving the care. You're just not getting credit for it. And a final note before we open things up for questions, and maybe this is because I'm a therapist, but again, also as a resident assessment coordinator and as a consultant, I see plenty of people considering reducing therapy staffing, reducing therapy minutes. I see it actually happening in some cases, and I really think we're going down a dangerous path, because CMS is certainly watching for shifts in minutes and in outcomes. So the question is, what sort of outcomes are they looking at? They'll primarily be driven by Section GG. And I kind of beat you over the head with the Section GG several times. This is the last time I promise I'll do it. But the outcomes are primarily, after October 1st of this year, Section G goes away in the MDS. And so the only way we'll represent function anymore is Section GG. And Section GG will not only drive PDPM scoring, but it will then drive the quality measures that show up on that 5-star nursing home compare site. Section GG, therapy also has a significant impact on rehospitalizations and trying to keep residents, whether we're talking about falls or whatever the case may be. And then the QRP program, the Quality Reporting Program. And I just want to show you a screen here. There's a lot of information on here. Where I want you to focus is right here in the middle of the revised QRP program, where they're looking at not just are you doing self-care and mobility scoring. Now they're looking already at the amount of change in mobility, the amount of change in self-care, and the discharge level of mobility and the discharge level of self-care. So in other words, what they're saying that what they're doing is creating the largest functional outcomes database in the history of humankind very quickly. And I'm not being hyperbolic here. You think about every single Part A resident. They're getting admit and discharge scores on, have been for quite a while. And this is where I say we're creating our future. If you keep in mind that they're collecting these in all post-acute care settings, you know that this information is going to be used for a future payment and perhaps placement system. And we might be writing that future with the way we're doing GG scoring right now. So it not only behooves you to focus on GG scoring, making sure you're really capturing your residents' level of disability accurately for PDPM, but I think for our future as well. So just some final takeaways, that I-20B coding is going to drive those 4 clinical categories. I definitely see situations where decisions made there are meaning lost revenue. And again, another way to state that is facilities that are not giving themselves credit for more complicated residents. Facilities that aren't offering restorative nursing is definitely affecting the nursing component of PDPM, especially for those lower 2 categories where a lot of residents seem to be sorting out behavior, cognitive, and especially reduced physical function. The addition of restorative or the sliding over of an ARD a day or 2 to catch those 6 days of restorative if you started late can make a real difference if that's where you're getting a lot of your residents. I mentioned depression. This is in the higher reimbursement, the higher case mix index nursing groups, special care high, special care low, and clinically complex. And again, depression makes a huge difference if it's a factor for your resident. And we capture that and depict that on the MDS, you're going to get credit for dealing with a more complex resident. BIM scoring, because there's such a high bar that forces us to do the BIM scoring, and I understand why they're doing that. They want the resident's voice, which I'm definitely in favor of. They want the default to go to the resident's voice, and it makes sense to me. But that's quite a high bar to say, is this resident rarely or never able to make themselves understood? And so we have to be thoughtful about how we're doing BIM scoring, make sure we're doing it consistently, because cognition really has an impact on that speech classification, and it escalates fairly quickly if you remember the CMIs for speech. The non-therapy ancillary points oftentimes are not captured because we're not getting broad input, and because it's looking all over the MDS for this information, and much of it comes from that I-8000 area where we need very specific ICD codes. And so it takes some attention to not only capture those things, get the input from everybody, but then to find the right ICD code. And then with speech, we see this high prevalence of the SA group. And just a reminder, the SA group is where we answered no to all 5 of those questions. And this is where I think having the SLP evaluate early on in many situations helps to answer some of these fundamental questions with PDPM, cognition, swallowing, and the neurogenically driven speech and language issues. And again, GG coding is something that I think is important, not just for PDPM, but for our future. So this is my contact information during questioning. I'll leave it up there. I made several offers for if somebody wanted to send me an email and ask me for some resources that I find to be helpful, that I reference every day, multiple times a day. I'd be happy to send you those. And so if you're saying, we need a special focus on NTA or speech or whatever, I can focus on that. But I do want to leave a few minutes here, Wendy, just in case there's some questions that have come in.
Great, thanks, Bill. We really appreciate the information that you provided for us today. We are open to questions now, so if you have any questions, please type them in the right-hand side of your screen in the GoToWebinar pane. And we'll give it just a couple minutes here. We have several more webinars coming up here at PHCA, so we hope that you'll take a look at that on the website and get signed up for them. We have an advocacy webinar coming up on March 12th. We're working on trying to get a workforce webinar lined up for later in March. We had a speaker fall through, so we're working on that, trying to get that rescheduled. And then we have a cybersecurity, something nobody wants to think about until it happens. So a little planning around, pre-planning around cybersecurity on April 9th, and another workforce webinar on April 23rd. And then we've got some webinars scheduled for May as well, and we're looking to have some outreach to get some webinars scheduled through the remainder of the year. So continue to look for those and any new webinars that might be coming up that might be of interest to you. All right, this is a quiet group today. I know here in Central PA it's a little overcast today. So I'm not sure if that's affecting everyone or not. We don't have any questions at the moment. We'll give it one more minute. Okay, we did have a question.
I will encourage people to reach out to me. Go ahead, Wendy.
Yeah, and I will provide Bill's contact information in the follow-up emails that I send later today. So you'll have that at your fingertips, everyone, as you go on. So we do have a question. There's a great deal of talk about CMS retooling, adjusting the payments of PDPM. Are you hearing anything about that?
Yeah, I think our first clue is going to be when the proposed rule comes out, probably in April, and so we're not that far away. I had thought they might react sooner because CMS said all along this is supposed to be budget neutral, and our sense is that the vast majority of providers are doing better initially under PDPM as far as their per diems than they did under RUGs. So it does not appear to be budget neutral. We didn't expect it to be once we got better at coding. And so I don't know specifically when it's going to happen, but I would bet the house that there will be some pullback. The question is, will they go retroactively, or more likely, will they just say going forward, we're going to change the base rates? That's the easiest way for them to go, to look at those base rates and to change them. If they find that they're 5 or 6% above where they want it to be, for instance, I'm just throwing that number out, that they change the base rates. So we may get some sense when that proposed rule comes out, but I expect it to be sooner rather than later. That's all the information I have, is that it's very likely to happen. It's very likely to be going forward rather than clawbacks, so to speak. But we'll know within the next couple of months here.
Great, thanks, Bill. And we did have a question about the handouts. Yes, I will be sending a link to the handouts in the follow-up emails as well. All right, any other questions? Well, like I said, just give it a little bit more time. If there's any more questions that anyone has, and know that, Bill is available if you think of something later on. All right, I think we'll wrap it up. Don't forget that I'll be sending a survey along with the follow-up email. So please take a moment to let us know, how we're doing, and if you have any other ideas for webinars, we're happy to look into them and schedule them. And I just want to thank Bill again for presenting on this timely and important topic. Have a great remainder to your day, everybody.
Thank you all.